Good afternoon, everybody. My name is Bob Christensen, and I am working with the CMTA to present these webinar series for you. And today we have a really interesting webinar for you on how to have hand surgery to restore thumb mobility and enhance function in children with Charcot-Marie-Tooth. Today we're lucky to have Tim Estilow with us from CHOP over in Philadelphia, and I've had the experience to look at his slides and speak to Tim a little bit, and I think everybody is going to be really impressed with what he has to say here. So what we're going to do here, just run over the controls real quick. You'll see on the right side of your screens in the control panel there's a place you can ask questions. In today's format, we're going to do just a little differently. Tim has asked that if we have questions throughout that apply to the content, that we will interrupt Tim and ask those questions in context with the slides that are being presented. We may not get to all of them, so our apologies in advance, but if you have a question as we're going along, just pop it in. I'll be monitoring, and if I need to cut in and bring Tim into it, then I'll do that. So having said that, I'm going to introduce Tim now. I'm going to turn the screen over for him, and he will share his screen and begin the presentation. So thanks, everybody, again, and give me one moment here. All right, Tim, you should be able to share your screen now and get going. And we do see it, so perfect.
Is there a way I can move up on the right side of the screen so I can see the slide?
I believe there's a little control in the upper right if you just minimize it. We don't see it on this end, by the way.
You don't see it, right.
That's hidden from us.
Okay, all right, I think I'm good. Okay, so good afternoon, everybody. Thank you for your time. As Bob said, my name is Tim Estilow. I'm an occupational therapist from the Children's Hospital of Philadelphia. I work in our neuromuscular program there and specialize in the evaluation treatment of children and also adults with CMT. I'll preface the talk with an apology to start. If I default to identifying someone as a patient or the word kids, that's just part of my daily practice. So I know we have a mixed crowd of parents of kids with CMT, adults with CMT, and then therapists as well. So I don't want anyone to be insulted. I'm not calling you a child. So now if I can figure out, here we go. So I want to start. These are my two lovely daughters that I'm most proud of. Olivia is 6 years old, and Rylan will turn a year on Sunday. So I just wanted to show off my two little girls. And now down to business. So what I'd like to talk about today is hand function in CMT, how hand impairment impacts daily life, and then give an overview of a case series that I published a few years ago on two young ladies with CMT who underwent tendon transfer surgery. So we'll start by talking briefly about the importance of thumb mobility for function. We'll do a background review of the case reports for the two young ladies I mentioned. I'll go into the decision-making process, so what factors led to their impairment in daily activities, how we decided that surgery may be beneficial, and then how we kind of work through that with the team to move towards surgery. I'll then briefly address the surgical intervention and the post-operative rehab. We'll review the results that the patients had following surgery, and then we can open the floor to some discussion and some questions. And as Bob mentioned, feel free to post your questions throughout, and I'm happy to address them. So first thing we have to consider is what are the main functions of the thumb. So the thumb primarily provides us with two functions. One is to stabilize, and the second is to manipulate. So throughout the day, the thumb provides an opposing force to the fingers for the execution of various grasp patterns. And on subsequent slides, I'll show you daily activities and these various grasp patterns. The second function of the thumb is to be used for manipulation. So shifting, rotating, translating, so moving objects within the hand and working together with the opposite hand for daily activities. So if you note in the pictures, you can see the various grasp patterns. So in the top left, there's what we call a gross grasp here, where the thumb needs to open, move away from the palm to secure grip on the shower knob in this situation. The thumb also provides stability when pouring. So without the thumb's ability to squeeze against the digits, it's hard to maintain a secure grasp on water bottles, milk jugs, any kind of object you would hold during the day. For dressing, you see a nice lateral pinch here, or a tip pinch to pinch the socks. So more of a fine movement pattern, but equally as important. So again, necessary to have the mobility of the thumb for that. And then when you look at the manipulative features of the thumb, to twist and move, to rotate, to remove the cap from the toothpaste. Some other activities you see in the top left, you see a nice key pinch here. So we need to be able to move our thumb to bring it towards the side of the index finger to secure the key. Same thing for the ATM card. If you guys are like myself, you swipe this thing a lot, so it's difficult to swipe the card without that thumb mobility. The movement of the thumb towards the hand and fingers and away from it to sort money or to count money. And then probably the ultimate these days, especially if you're a teenager or have a teen or even an adult, is thumb mobility for operating a cell phone or a tablet. My favorite things, as Bob and I just discussed, Bob brought up a good point of stemless wineware, making it more difficult because it's hard to open up the hand and get the hand around the large base of the glass. And if you look at the nice slice of pizza here, you can see the wide aperture, so the wide opening. So the thumb really needs to move far away from the index and other fingers to secure an object. And without that mobility, it's hard, with one hand to hold your drink and hold your pizza. So we showed some of the things that happen with thumb mobility and with stabilization, how you can function during the day. And this is just a cute video I came across of a cat trying to open a doorknob. The cat obviously doesn't have, whoop, this isn't working here. Doesn't have the, let me see if I can get this thing.
I think it's running behind you there, Tim.
Yeah, so the cat doesn't have the opposable thumb. We don't want that. Let me try to load it again. If not, we can bail on this. It's not essential. So you'll see the cat reach up, trying to turn the doorknob. If it was a human, you'd have the fingers to try to grip, but no opposing force on the other side, so you can't secure the knob and you can't rotate the knob. So the cat gets frustrated and walk away. So a lot of the kids I see at our clinic and a lot of patients I talk with, when you lack that thumb mobility, it really makes basic daily tasks such as that difficult to perform and can lead to a high level of frustration. So that takes us to our OT evaluation. So when you go to your local clinic or your outpatient setting and you see your occupational therapist or your physical therapist or hand therapist, the discussion should really be based around what are the activities of daily living that you're struggling with. So ideally you want to identify what the functional deficit is. So for example, it could be opening the hand to hold a cup. It could be bringing the thumb to the small finger to pick up a small piece of food. It could be turning the pages in the book. And then you want to look at what are the contributing factors that are causing that impairment. The next step is to quantify. So you want to discuss what the level of assistance is. So someone's able to do it independently versus they can do it independently with increased time. So it might take a person with CMT 2 minutes to button a dress shirt where somebody else could do it in 30 seconds. So it's important to quantify what the level of effort is, what strategies they use, and then how efficient or how long it takes to complete that activity. Also, we like to look at strength. We like to quantify strength and range of movement, so we can put a numerical value to monitor progress or regression over time. The CMT Pediatric Scale is a scale that we developed specifically for patients with CMT that includes items that look at hand function as well as other areas. So in this case series, I used fine motor measures and the hand strength measures from that scale to monitor the progress of our patients. The next step is to discuss possible therapeutic interventions. So what can we do for you? Are there exercises that you can do? Is there underlying muscle tightness that's adding a higher level of resistance to natural movement? Do we need to put a stretching program or a nighttime bracing or splinting program into effect? And then the final thing is there any available splint orthosis that we can trial that will improve function? And the key thing here that I think is really important is that there's no real benefit to wearing a splint orthosis during the day if it's not going to improve your function. So if you have some tightness, if you're worried about a hand deformity and you're worried about possible contractures developing, nighttime when you're sleeping is really the time when you can put a splint on that'll give you the stretch that you need overnight and prevent those issues from occurring. During the day, we want the thumb to be able to move if you have thumb mobility. If you don't have any thumb mobility, and we can provide you with a splint orthosis that will facilitate that or position the thumb so that it can be utilized, that's the ultimate goal. So walking around with a splint on during the day that keeps your hand open and immobilized is not the outcome we're looking for. And then once we trial the device, we want to reevaluate the functional measures we talked about. So when we have the device on, we want to look at your strength, we want to look at your dexterity, we want to look at your functional task performance and see, does that device improve your performance? And if it does, then there's benefit to using it. If not, then further discussion. Next, I'm briefly going to go into the two cases from the study. First, the 6-year-old young lady with CMT Type 2A. She has a mitofusum mutation. You can tell by looking at the pictures, she's got a good degree of wasting in the intrinsic muscles you can see between the fingers. She's got clawing of all digits, so not just the ulnar digits, generally the ulnar digits, the small finger and the ring finger, the first two to claw. This young lady had clawing of all the digits. As you look at the picture of the volar surface of the hand, you can see the wasting in the thenar area, so that's the area right around the base of the thumb. That's where the musculature is that brings that thumb across the hand. So you can come across and you can pinch and pick up things with your fingers. You can secure objects. So she's got severe wasting. And then you can even see, if you look closely here, if you can see, can you guys see the mouse?
Yes, we can.
Okay, so you can see in this area here a little bit of the wasting of the musculature within the palm itself, and then the hypothenar, which is the sonnet digit with the small fingers. You can see how that swoops kind of down there in a divot. So those muscles have atrophied as well. So due to the weakness and due to the atrophy, this young lady really had very, very limited thumb movement. She wasn't able to oppose the thumb to any finger, so she couldn't touch the pad of her thumb to any of her fingertips. She couldn't bend the thumb. The only movement she really had was to take the thumb from the side and then move it against the index finger, just at this first joint. So kind of like a scissoring type grasp, we would call it. Functionally, she wasn't able to execute any of the fine motor precision pinch patterns that we looked at earlier in the picture. So not able to do pincer grasp to turn a page in a book, the 3-jaw chuck grasp or palmar pinch that you use to untwist the toothpaste or to tie your shoes. She was unable to execute that. And the lateral or key pinch, she was unable to execute as well. She relied on compensatory patterns where she would rake things, the fingers, so she'd put the hand over the object, curl the fingers up to try to bring the objects into her palm. She'd scissor things between the index and middle fingers, or for larger objects, she would just hold with a palm-to-palm grasp with 2 hands, so really eliminating the use of the other hand for a separate function during bimanual tasks. Functionally, she complained of difficulty opening doorknobs, tearing open snack containers, manipulating the top of drinks, juice boxes, buttons, zippers, all different clothing fasteners were challenging. And then from a leisure standpoint, she liked playing cards. It was very hard for her to pick the card up off the table and turn it. So you can see the functional impairments really carry across a lot of different areas, from self-care activities, meal preparation, leisure activities, and then community access when it's difficult to open doorknobs. She had surgery 6 years old. Both girls had surgery on the non-dominant hand first to see how they would benefit before moving to the dominant hand.
So if we could, for 1 second, Tim, go back to that previous slide. We have a question here from somebody. It's more of a statement, but it's a person who has a 13-year-old son who's having arthritic type pain, and if asked to move his wrists up, to move hands up, his fingers automatically claw. Can you, is that a normal thing, or can you describe what's happening there?
So arthritic pain or joint pain isn't something that I hear as a common complaint with wrist extension. A common complaint that we will hear is fatigue with writing or cramping of the hand, so that's fairly common. Pain in the actual joints themselves with movement isn't something that I come across frequently with CMT. The second half of that, when they're trying to bring the wrist up, in general, CMT is a peripheral neuropathy, meaning as I mentioned, the longer the nerve and the more distal the nerve and the musculature is, the more impaired it is. So most patients will kind of have hand impairment, but wrist strength, elbow strength, shoulder strength is pretty normal. In the case that there's more proximal impairment where the wrist extensors are weak, what the body will do is the body will compensate, and the body will utilize the muscles that extend the fingers and open the fingers to assist with elevating or raising the wrist. So what happens in that situation is the balance between those large muscles that extend the wrist and the large muscles that open the fingers overpower those small intrinsic muscles within the hand that are responsible for the manipulation, for the balance. So what happens is the fingers end up clawing, and you get that claw deformity when they go to open the hand. And there's different options. There's different splitting options you can do there. They can, therapists can easily make a blocking splint that blocks the thing that would come across between the first knuckle, which is called the MP, and then the second knuckle here, the PIP. You can make a splint that can easily slide on and slide off. That would go there and would block this clawing motion that you see in the slide. And what happens is when you go to open the fingers, instead of you getting the extra extension or the hyperextension at this joint here in the clawing, the force gets distributed further along the finger, and these digits that you see that are bent at that middle knuckle here, the force gets redistributed and they'll fully open. So you could still it'll allow for better opening of the hand in the presence of a claw deformity. The pain, if there's still a lot of pain, I mean, that's something I'd recommend seeing an orthopedist about to see if there's anything else going on, or possibly rheumatology if there's other joint pain issues.
Thanks, Tim.
Okay, yeah. So second young lady is a 12-year-old girl, not confirmed, but likely CMT Type 2, very similar to our first patient. No opposition, no palmar abduction, no flexion of the thumb, severe wasting of the hand. This young lady, similar to the case I just discussed, decreased wrist extension strength and decreased active finger extension. So she had clawing and she was unable to fully open the fingers. Functionally, similar presentation, no pincer, no 3-jaw, no lateral pinch, same compensatory strategies as the previous young lady. She identifying opening containers, stabilizing objects in her hand, bottles and cups, and then manipulating clothing fasteners is the primary thing. The ability to stabilize and use the thumb, something we kind of take for granted, to stabilize the computer mouse to operate the keyboard, to operate computer gaming devices was impaired. And then picking up some snack foods. So she'd like to pick up small snack foods. She'd have to rake them in her hand and then kind of try to move them to her mouth. She wasn't able to use that precision pinch. She initially had surgery to the non-dominant hand at 11, and then subsequently, about a year later, the dominant hand when she was 12. So, backtracking a little bit, at the evaluation with these two patients, I went through the history, I talked with them, I talked with the parents, we looked at some ADLs, we identified what the impairments were, and then we discussed what's the limiting factor, why aren't you able to perform these tasks? And we identified the lack of thumb mobility as the single biggest limiting factor. So the next step, as I mentioned before, was to trial some different devices that could either position the thumb in an improved alignment for function, or kind of try to facilitate some movement if there was some active strength there that they weren't able to fully utilize. So these are just 4 examples. I'm not endorsing any of these specifically. They're just 4 of the most common approaches. The Bennett splint, a soft neoprene splint that you can see that can supply and provide support to the thumb to get it over into more of an opposition standpoint, so to move the thumb from being aligned next to the fingers to where it comes under the palm where it can oppose the fingers. The second is a McKee splint, which is a little more low profile, that if you don't need the wrist support, does the same thing. You can see this nice C-shaped pattern here where the thumb is able to be positioned away from the palm, and then if you bend the fingertip or you bring the index fingers down, you can pinch and grasp there. These are good for kids, for patients who have some active movement and just need a little bit of support. If there's no active movement of the thumb at all, you can trial these. If the support's not sufficient to keep it in place, your therapist can make, out of plastic, out of thermoplastic material, can make an opponent splint that'll position and keep the thumb in that same position of opposition where the fingers can then come down to meet the fingertip to execute. The fourth option is Kinesio Tape. You've probably seen infomercials for Spider Tech and Kinesio Techs, and if you watch the Summer Olympics, you'll see all the volleyball players are taped up from head to toe these days. This tape can mimic muscular movement, so it can be applied in the same motion that the muscles that move the finger and bring the thumb across the palm would work. So it would also, if there's no movement, it's not going to help you. If there's some movement or some decreased strength, this is something that can facilitate and get some more movement. These options, the primary goal with me trialing these options with the patient is to mimic what a surgery would potentially give you. So what you want to do is trial the device, and then you're going to repeat all the testing you did without the orthosis to see how it changes function. So I did that with these 2 young ladies. We had a decision to make, okay, what are we going to do moving forward with surgery? So the next step is really to look at my clinical experience and then also the body of literature to see if there's evidence and if there's support for this type of procedure. So I worked with a lot of patients who have had tendon transfer following peripheral nerve injury. It works very well. There's a large body, I have 4 referenced here, but there's a large body of literature for tendon transfers with patients with peripheral nerve injury. There's some reports for surgery in adults with CMT having tendon transfers. Not a lot, but there are a few. I came across 3 of those. But I wasn't able to identify any literature for the surgical management in pediatric CMT. So that's the challenge that this case really presented was, we know it works for kids with a different diagnosis but that have nerve impairment. We have no confirmation that it works in pediatrics with CMT, but we know that it has worked in small studies of adults with CMT. So the next step was really, for the family to talk with myself, with the neuromuscular team, and then with the hand surgeon, and to ultimately do a cost-benefit analysis and see what's the risk here and what are we going to get out of it. So the 2 young ladies we had, their level of impairment was severe. So the thumb function was almost non-existent. It wasn't contributing to assisting with ADLs. The potential loss in function from the transfer is minimal. So when you take a muscle that has a primary purpose and you relocate it to carry out another movement, you will lose a little bit of strength in that initial primary goal, and we'll go over what that is specifically in a few slides. But the loss in this case was minimal. So the way we kind of looked at it was, we're not really going to lose much. We have a potential large benefit to gain, and the next step was to discuss how the surgery goes, what the post-operative therapy is, and then what we expected functionally from the procedure. And it's important to really discuss in depth, especially, the surgery is an easy thing. You go to sleep, you wake up, it's done. It's the post-operative therapy where you have to get in 3 days a week initially and 2 days a week, and you got to do a home program. It's that when you're dealing with either young children or if it's a case of an adult who's working, you really need to make sure that it's going to fit your lifestyle for that 3 to 6 month roughly period after surgery that you're going to need to kind of rehabilitate and maximize the function of surgery.
Hey, Tim. Just want to interrupt here. If we could go back one slide for a second. I have a question here about, well, it's a two-part question.
Sure.
First, is there any sort of list of surgeons or anyone who specializes in this sort of surgery for CMT specifically, especially pediatrics?
Yeah, so pediatrics in the Philadelphia area where I'm at, I use Scott Cozen is a pediatric hand surgeon that I've worked with for years, who's at Shriners. We have Dr. Rob Carrigan is a pediatric hand surgeon who's at CHOP with me. The easiest way to get to that information would really be to reach out to the CMT Association to identify the center of excellence that's the closest to you, and then you kind of go to them identifying who the surgeon is there. I don't, as far as looking at all areas in the country, I don't know in Kentucky who the hand surgeon is. So that's where I think, the people in the advisory board, the actual centers of excellence, the physician practice and the therapist there should have a local surgeon that they're familiar with who can advise, and provide consultation for the patient.
All right, thanks. I think you answered both questions there. Thanks.
Okay, so surgical intervention. So we know CMT is length-dependent progressive polyneuropathy. So ideally, you want to select a muscle that's more proximal, so closer to the body, that in general is less impaired in CMT. So the muscle that is used with this transfer is called the FDS, the flexor digitorum superficialis. So this is the muscle that bends your finger, and specifically it bends that middle joint of your finger. It's an ideal muscle because the muscle itself sits in the forearm, in the upper forearm, close to the elbow crease. So it's not something that's devastated, usually involved early on, and it's a muscle group that maintains fairly good across the lifespan with children and adults with CMT. The other thing that's advantageous about this muscle, its primary job, as we discussed, is to bend the middle joint of the fingers. However, there's an additional muscle that also provides that same motion. So when you remove the FDS from the targeted finger, so in this case you'll see it's the middle finger, when you remove the FDS, there's still another muscle called the FDP, which can actively bend the finger as well. So you may lose a little bit of strength potentially, but the movement is still there. So both girls underwent long finger opposition tendon transfers in non-dominant hand. I'll show you some slides and pictures from the surgery. Preoperatively, a quick screening takes place. You can see the FDS muscle is the one that originates up in the forearm, runs in a straight linear fashion down through the palm. The tendon attaches to the middle phalanx, and you can see it bends the finger. So it takes the finger from straight position to bending it. So the physician targets, checks usually the ring or middle finger, see which one's stronger. And then the next step is once they identify which one's stronger, they want to check that other muscle, the FDP we discussed. So they'll block the finger and they'll evaluate the strength of that FDP. If that muscle is good and strong, then you know it's still going to be able to sustain full functioning of this hand to bend the finger in the same capacity. Next, they isolate and identify the tendon in the forearm where it originates. They go distally to where it inserts, and they detach it. And you can see this beautiful picture here, the tendon retracted up through the palm. You can see this pink fleshy area is where the muscle and the tendon join. Now, the next thing that's really important step in this process is that muscle primarily, as we talked before, functions in a linear fashion. So it starts in the forearm and it runs in a straight line down and it attaches at the middle finger. So its line of pull is a very direct linear relationship. In order for us to get it to move the thumb and pull the thumb across the hand, a pulley has to be created. So another tendon is used from the flexor carpi ulnaris, another muscle in the wrist. That tendon is dissected into two pieces. They pass the tendon through and then bring it across the palm. So what happens here is the muscle comes down, it's rerouted through this pulley, and you get this arc of movement so that when the muscle contracts up here in the forearm and the tendon pulls, I'm clicking away here, and as the tendon pulls, it'll bring, and you can see the tendon sticking up out of the skin here, it'll bring that thumb across. So that tendon gets woven around the abductor tendon. They position the hand in a little bit of wrist flexion and the thumb in opposition. So this is to protect the tendon. So once this gets adhered surgically, you don't want to provide any force that's going to stress it or cause that to come apart. So that's why the thumb's put in a protective position. After surgery, there's 3 different phases. There's a first phase is immediate, is the immobilization period, lasts 3 weeks. The patient's casted. The main goal here is you want to protect that transfer that just occurred. You want to prevent adhesions. So where those tendons, you can see where they overlap, it's important that they don't get stuck because they need to move freely upon each other. And then you want to maintain range of motion of the uninvolved joints. So the elbow, the other fingers, you want to make sure that they're able to move because you don't want stiffness occurring. So for the first 3 weeks, you're in a cast, you're moving the other fingers actively, and you're performing these tendon glides here to get the tendons moving independently of each other so you don't get any adhesions. And then DIP blocking, that's a picture you saw where they were testing that DIP muscle so that it continues to maintain its strength to flex that middle finger that had the donor tendon removed. After 3 weeks, the cast is removed. The therapist makes a dorsal forearm splint, so it's a splint that goes in the back of the hand. That's going to keep your wrist flexed a little bit, similar to how it was in the cast, and the thumb opposed, again, just to protect that transfer. But what it's going to allow you to do is to actively move the thumb and start some active movement. The next step of that phase is to enhance the control. So you want to get initiation of movement, and then you want to get isolated control. So I have pictures of 2 techniques you can use here. You can use biofeedback, so muscle sensors can be put, and these pictures aren't specific to our case, so obviously it's a leg and a distal forearm, but it'll still illustrate the principle that the machine will recognize that you've activated the muscle, and then it controls the little video game character on the screen. So in this case, you would put the sensor on the forearm, on the muscle that would bend the middle finger, and as they activate that muscle, the thumb would begin to move. And the goal is that you provide the visual feedback so that they can gain enhanced control over that finger to do it, to do it without the conscious effort. Some of the things we do with the kids, we'll put stickers on their hands and try to reach for. I'll draw a face on the palm and a little mouth so that when they move the hand, it looks like the lips are moving. And the first goal is just whatever you can do to get active movement. We want to get that transfer firing. We want that muscle to be strong. We want to get as much movement as possible. 6 weeks out, the splint's only worn at night, and then only for daytime resistive activities. So when we're starting our strengthening, we use the splint to keep the hand in a good position to prevent injury during that activity. Now we move from just looking for any kind of active movement to try to get some functional movement patterns. So we want to try to establish that lateral, the key pinch, the opposition, bringing the thumb to the fingertip to pick up small objects, and then the abduction, so moving the thumb away from the palm to open the hand in preparation to grasp a water bottle, to grasp a softball, football, baseball, whatever you're using. And then we start to look at specific ADLs. So whatever the priority is. So in our case, it was using a Ziploc bag, stabilizing the computer mouse. So you want to start, it's important to work on the active movement and isolate these movement patterns, but even more important is to really practice and learn how to utilize that new thumb mobility for the functional tasks. One of the challenges initially is, depending on when the surgery occurs, so the one young lady was 5, the other girl was 12, they've developed compensatory movement strategies over the course of their life. So from a behavioral standpoint, they're used to using the hand in one fashion. Now you give them a whole new movement potential, and you really have to try to break those compensatory grasp patterns and utilize the new movement so you can be more efficient with daily activities. And that's something that can be quite tricky. Okay. Week 8. So this is when we can start some strengthening. So you should have some movement going, functionally using the hand, but you want to maximize the strength here. It starts with light resistive activities, so sponges, water play, Play-Doh, putty. Then you can move on to more resistive stuff as grip strengthening, light weights, and other resistive activities. For the kids, we like to play games. Kids like games, so we'll use tongs, tweezers, resistive clips to function instead of using just our fingers to pick up a game piece. They'll squeeze the tongs will pick up the game piece. So, with the young children, it's really how can you sneak in the resistive work into their daily activities. With adults, you can do more isolated, and teenagers more isolated strengthening. Once you hit 12 weeks, this is really kind of like the work hardening phase, the ADL maximization phase. Where are we still lacking? What do we need to do to maximize full function of the hand and continue with strengthening and enhancing dexterity? The splints discharge completely, and it's very important. But from a therapist standpoint, it's very important that the patients have specific goals identified. So unless you're able to illustrate what you want to be able to do, and we can kind of simulate it prior to recommending surgery, or what we're going to work on after surgery, it's hard to kind of go in blind and just say, yeah, I want to be able to get you to move your thumb more so you can use your hand better, because it doesn't give us a good basis to work off of. So the results. So the first young lady, I got some preoperative measurements here, and then postoperative 11 months afterwards. So she had a small decline. So gross grasp is the ability to squeeze with the thumb and all the fingers, like you would hold, you could hold the water bottle, like you would carry your purse around. So she had a little drop off in her strength here. What I don't have on this chart, unfortunately, is the data from the non-surgical hand. The non-surgical hand also had a decrease in strength in this grasp pattern. So I can't say whether it was related to disease progression a year later or whether it was related to that muscle transfer. Prior to surgery, we talked about she was unable to execute any of the pincer grasp patterns. After surgery, not only was she able to execute the grasp patterns, but she was able to obtain some force. So 1 pound doesn't sound like a lot of force, but later on in one of the slides, I'll show you what 1 pound of lateral pinch strength enables you to do on a daily basis. She had a modest change. It's basically the same for the 9-hole peg test. This is a test that looks at finger dexterity. The reason I think this is, she was the first young lady you saw that had all kinds of the clawing of all the digits. So even though she had new thumb mobility, so you can see she was able to oppose all the fingers except the small finger, where before she wasn't able to oppose at all. She had no palmar abduction. Now she had 30 degrees, and she had a little bit more radial abduction. So she had more movement of the thumb, but the other fingers have to still cooperate with the thumb to manipulate objects. So that limited her improvement on my whole peg test. The functional dexterity test is a test where there's a wooden dowel that's black on one side and white on the other side. The child picks it up and they flip it over in their hand and put it back into the board. So there she showed more of a marked improvement because that test relies really on more mobility of the thumb. Functionally, which is, again, to me the most important thing, we have some nice measurable gains here that we can look at from a quantification standpoint, but from a qualitative standpoint, she was a right-dominant young lady who, after surgery to the left hand, started using the left hand in the dominant role for manipulative tasks. So she would stabilize the object in her right hand and then use the left hand to unzip it or to untwist or to try to snap. She was able to utilize that lateral pinch to open a Ziploc container. She was able to maintain the grip on her yogurt, to peel the lid off her yogurt for her snacks at school. She was able to pick up snack foods easier. She wasn't able to button, so she could, she was able to button. She was able to use the pincer grasp to button. She wasn't able to snap because she didn't have the strength to snap. But she could now maintain the grasp on the zipper to zip and unzip for clothing management, and then playing cards was something that was important to her. She was able to pick up and manipulate those playing cards much easier. Second patient here, she had both hands done. I have longer outcome measures on here, so I have her up to 4 years with the left hand and then up to 3 years with the right hand. Grasp strength, a small drop-off after surgery, in that year and a half after surgery, but over time continued to gain strength. So it doesn't appear that taking that muscle impacted her strength at all. Her lateral pinch, she used a modified pattern before. After surgery, she was able to execute it effectively and then continue to gain strength as she aged. Same thing with the pincer patterns. She had some real marked improvement in her testing, where you can see she went from 127 seconds to 50. So she really was able to have improved dexterity and use that thumb to grasp, manipulate, and target and release for our fine motor dexterity measures. And even changed, lost a little bit over the 4 years, but still really maintained far superior to where she was. And this is in the face of disease progression. So, the other muscles, and I'll show you a video of her later, the other hand muscles continue to progress, lose strength, and lose function, but the thumb transfer still remained intact. And the right hand, similar things. You can see the 2 dexterity measures. She had nice drop-off in performance, so the lower time's better. She completed it quicker. And again, continued from 9 months to 38 months. So over that span, continued to improve her skill and her dexterity. Here's some quick pictures just to illustrate. Pre-operatively, this is her trying to bring the small finger over to touch the tip of the thumb to touch the tip of the small finger. She was unable to do it. Post-operatively, you can see the beautiful, you can see the tendon here coming out, which is a real nice illustration of how it pulls, and it pulls that thumb across, and she can get to the tip of that small finger. So real beautiful active opposition after surgery. This is the board for the 9-hole peg test. Before, she would slide the thumb against the side of the index finger, so a compensatory grasp pattern, which would make it hard. The pegs would slip out. Afterwards, she's able to get the tip of that thumb, the pulp of that thumb against the peg, and then also against the index finger. So she really had a precision pinch to pick up and place. This is the functional dexterity test. So you can see the thumb's kind of absent from being able to move and flip and rotate that peg over. Post-surgery, again, you see this beautiful kind of C or U in this position shape where the thumb comes out of the hand and is able to work against the 2 fingertips to rotate that peg over. So this active movement is what allowed her to improve her time on here, but not only that, to enhance her function. So, yep.
I have a quick question for you. Someone has asked how much time you should wait between hand surgeries.
Good question. So I don't know that there's a definitive answer to that. So I think the younger, my thought, because I'm presenting 3 cases, right, from 2 girls. That's an extremely small sample. But my thought is the younger you have it, the quicker you recover. Youth plays a big role in recovery. Neuroplasticity and the ability to kind of reorganize from a central standpoint and use this hand in a different way. Youth helps you there. You need to fully recover and maximize the function from one before you go on to the other. So I think on the short end, maybe 6 months, because you really want to make sure that you got the one solidified, done, and then you're on your way with your home program. The fear of the longer you wait is if you're starting to develop contractures and you're having joints that are getting tight and you're having tendons that are shortening and muscles that aren't moving as well, then you're adding resistance to movement. And in addition, that the muscle that you're transferring, if it's weaker at the time of transfer, you might not get as good of a result. So I don't know that there's set guidelines. The other piece is, what can you really afford to do? So not from a financial standpoint, but from a lifestyle standpoint. So if it was myself, maybe I could afford to be out of work for 3 months to get the left hand done, but then I'm going to have to work another year to get back on my feet and get the right one done next year. I can't take 6 months off. If it's a kid, you might have to look at, are they involved in sports? Is it during the school year? Are you doing it during the summer? So the timing really, lifestyle plays into it, and then what their kind of their clinical presentation is as well. So sorry I can't give a concrete definitive answer, but there's a lot of factors that contribute. Okay, so here's 2 videos again of that thumb opposition post-operatively. 3 years later, you can see the thumb remains at the side. She's able to execute and bring it to the small finger to pinch. 4 years later, you'll notice the small finger is not able to come across the palm as much. So in this picture, the small finger is able to come and join and meet the thumb. As her disease progressed over the 4 years, she got more wasting of these muscles on the outside, on the ulnar border of the hand, and her ability to move the small finger towards the thumb decreased. But the ability to bring the thumb over remained intact. Because again, that muscle you're taking, that muscle you're targeting and you're using as a donor muscle is located up here in the forearm. So it's a more proximal muscle. It's less impaired. So it's going to sustain longer than small muscles that are located within the hand. So I know that's a big question. With disease progression, is it going to sustain? So the furthest I have is 4 years out, and as you can see, the thumb still maintains function. The other thing I want to point out briefly while we're on it is when I'm talking about strength of donor muscles, these two girls are extreme cases. So if you look at the grip strength for the first young lady, she only had 4 pounds of grip strength. So a typical healthy girl at 5 years old, 4 or 5 years old of her age, would have around 14, 15 pounds of grip strength. So you're already talking about a hand that's extremely weak and a donor muscle that we used that was weak. So it wasn't what you would call a normal strength donor muscle. The other young lady, she was 12, and you could see only 5 pounds in the right hand and only 10 on the left when she was 11. Again, that's someone who would be in the low 30s, high 20s, low 30s. So a third of the strength that you would anticipate for a female that age. So we're not talking about two girls here who had good, strong finger flexors that we moved. We're talking about girls that had weak finger flexors that we moved. This is kind of an alarming thing here, and the stat's 4 years old. I'd love to see what it is now, but in 2011, American teen girls set a median of 100 texts per day, and teen boys set 50. It's probably quadrupled by now, so between the Facebook and everything else. So this is a huge area of emphasis for my patients, and I'm sure for adults as well. So the ability of her to get her thumb, one, just to secure and hold the phone is huge. And then the second piece is not only can she secure the phone better, now she's able to actively move that thumb to type. She's emailing me here, so she was able to send me an email. So great goal for this young lady and something she was able to do. So some overall discussion points. The first thing that I wanted to look at with this case series I did was what's the efficacy. I wasn't able to identify any literature in pediatrics discussing hand surgery. I talked about there was a little bit of literature in the adult population. So does it work in kids? So what I noticed in these two patients is there was immediate postoperative improvement. So as soon as that cast was removed and they started in therapy, their movement was better, their execution of grasp patterns was better, and their time testing was better. And most importantly, they were able to take that new movement, the new strength, the new grasp patterns, and able to apply them to improve their function in daily activities. Second question I had was sustainability. Is this going to sustain? We know CMT by nature is a progressive disease. How long will this transfer remain effective? So we're 4 years out now. The young lady who had it 4 years ago, her active range of motion still remains intact. The grasp patterns that she's had, she's retained those grasp patterns. We touched a little bit on her manipulative skills have been impacted by disease progression. So the function of those other fingers, so the thumb's still moving nicely, but the other fingers aren't able to work as well with the thumb. So some of the higher level manipulation stuff is a little bit more challenging. But the ADL improvements that she identified, so holding the mouse, turning the paper, all of those things, using the cell phone, have maintained. So the furthest we're out now is 4 years, and she looks good. The adult literature is small. There's some small patient samples. There's not a lot of measures in range of motion. There's not a lot of standardized testing used, but they just discuss functional use that the adults have maintained function. I think the longest was at like a 10-year follow-up. Not that they don't remain at past that, but that was the longest at their follow-up, similar to my 4 years. Limitations in the case series. Again, small sample size. I have 2 kids. They're not, CMT is a very heterogeneous disease from a phenotype standpoint. There's patients with very, very little impairment, low-level impairment. There's patients like these 2 young ladies who have severe hand impairment. So they're not representative of CMT in general. I thought it was interesting to take 2 patients who you may consider poor surgical candidates because they already had significant wasting, they already had no thumb, limited, very, very limited thumb movement, and they had weak donor muscles. So I was excited to see that when you look at a patient that has a very severe presentation at a very young age, you were still able to have success with the tendon transfer. So the next step is considerations moving forward. So we talked a little bit about breaking fence movement patterns. We talked about dependency on the other fingers, and intrinsic function of the other fingers to work along with the thumb. So the next step is to look at other surgical procedures. So there's other surgical procedures that could be done to the other fingers to complement the thumb mobility, and would also use donor muscles that are more proximally innervated muscles. So moving forward, maybe it's a stage process where you do the thumb first, and then you do some intrinsic transfers later on to really enhance hand function. And the other way that I'm kind of looking at this now is it's very apparent to look at a patient with severe wasting of the hand and a lot of weakness and see how it impacts their daily life. But I started to consider my patients that are more mildly impaired and are starting to lose some thumb mobility but have significant grip strength. So 40, 50 pounds of grip strength, but they're losing the ability to pinch with the thumb. They're losing a little bit of thumb rotation. And that might be the possibility where you have somebody who's a lot less impaired, has a lot stronger donor muscle, and potentially could have an even better result from surgery because you're using a stronger donor muscle and disease hasn't progressed to the same nature. The last thing as far as considerations is most of these young ladies were weak. They were able to execute new grasp patterns, but their strength wasn't impressive. So you saw there was a 1 pound for the one young lady and 2 to 3 pounds for her pinch strength, which isn't a big impressive number. But when you look at the lateral pinch, so the lateral pinch, that's the key pinch, the amount of force that's required for specific daily activity. So the scale's in newtons, so 5 newtons, which is this red line here, is 1.12 pounds of force. So all the boxes show the range of strength that's needed to complete the activities that are listed below. So with 1 pound of lateral pinch that both of these girls received for the procedure, you can operate the remote, you can do opening the zipper, you can take a key in and out of keyhole, the ATM card in and out, looking at the Ziploc bags, and then just above that, it gets to using a fork and plugging in outlets. So when you think of things that we do all day long, TV, cell phone, credit card, debit card, clothing fasteners, all those things, that 1 pound of lateral pinch strength is sufficient for a lot of things that occur during the day. So it may be the mobility, the ability to get the thumb there to use to stabilize, that's more important than a big impressive number. So in conclusion, I presented 2 pediatric patients, 3 cases, severe hand dysfunction. They both underwent FDS opposition tendon transfers. They had immediate improvement in hand function following surgery. Both patients were highly satisfied. The one young lady went back immediately for the other hand to get done. The second one, I think it was again, we talked about lifestyle before. She was in kindergarten, just starting brownies, I think. I don't remember the exact scenario, but at that point, it just wasn't a good fit to go have the other hand done. And also, she was functioning quite well. At the time, there's no perceivable negative impact, so there's nothing that I've seen from following these girls that was a downside or a bad effect of the surgical procedure. Their grip strength continued to maintain or improve. The function over time continued to improve, so there wasn't a downside. There are scars on the base of the forearm, at the wrist, and at the hand that, when managed properly, will reduce the visibility of, but there are scars because of surgery. And then the impact of going through an operation, being out of commission for a couple weeks when you're a cast. So that's the downside, but in this case, the upside was improved function. So I think it was definitely worth it. And we need a larger sample size, so we really need to be able to look at these type of procedures with various type of patients and establish a large cohort of patients to learn more about who benefits from surgery, what types of post-operative therapy are most beneficial. Is there a difference between operating on the dominant and non-dominant hand? So maybe skills after surgery are attained faster with the dominant hand because that's the way the dominant hand functions in a manipulative role. Maybe strength gains are improved quicker with the non-dominant hand because our non-dominant hand functions as a stabilizer. So there's other questions to be addressed. The last slide here is a few questions that I received before the talk that I tried to address throughout. So can the procedure be done in adults? yes, it can be done in adults. No, you're not awake for the procedure. You're sedated and put to sleep. Recovery time, so we touched on that. So you're immobilized and casted for 3 months. For 3 weeks. Generally, around that 4-month standpoint is when you're making decisions. Do I need to continue with, the weekly, 1 day a week therapy and home program, or am I sufficient? Have I improved enough to go along with my home program and then do intermittent follow-up with your therapist? Can both hands be done at the same time? So technically, yes. I would say no, because from a standpoint, if you have both hands locked up in casts, it's going to be very hard to function. And then also, it's going to be very hard to have the time to dedicate properly to rehabilitate both hands at the same time. In terms of statistics, I presented a few things today on strength and range of motion. The adult papers that I reviewed at the time of publishing this didn't have a lot of quantifiable statistics in terms of what the success was. It was more patient-reported outcomes, which is important as well. It's just hard to measure. How long can the benefits of surgery be expected to last? That's open-ended. I've seen it up to 4 years. Some of the adult literature suggests longer. That'll really depend on the progressive nature of the disease and then and the individual patient. Can the surgery be, so this is a good one, can the surgery be repeated if the effects wear off? So I don't know. Each of the 4 fingers has that FBS muscle. Generally, the strongest muscle out of those 4 is the one that's taken to transfer. If that muscle degenerates over time with disease process, chances are the other 3 that remain have degenerated as well. So I don't know that would be it would be a likely candidate to serve as a good transfer. So that would be a question for the hand surgeon himself. But my thought is, if the muscle that was transferred that was the strongest to begin with degenerates, the other ones have probably degenerated as well because they're supplied by the same nerve. So here's a list of the references that I cited throughout the paper. So if you want to find more information on some of the outcome measures on the surgical procedures in adults, peripheral nerve injury, these are the citations.
So I have a couple other questions here for you, Tim. And first, the first question is, do patients need to continue therapy long-term? When they're released to a home program, how often are they monitored by an occupational therapist, et cetera? So the way it works at CHOP is the patients follow up in our neuromuscular clinic or in our CMT clinic. So they come in depending on their need. They'll come in. Some kids will come in 3 times a year. Some come once. Some come twice. So they would come into the clinic. They would see the OT, the PT, the neurologist, the dietitian. They'll see the whole team, whoever they need to see. And at that time, I would evaluate and decide, do they need more therapy? So they may come back for work on their balance. They may come back for work on core strength. But as far as the hand, you need that immediate kind of quick hit to rehab, to maximize. And then you need sustained performance with daily activities, and you're strengthening. You make those strengthening things part of your lifestyle. And with CMT, you should really be. The goal was not to be in therapy once or twice a week for the rest of your life, but for us to bring you in, maximize your function in a short window as much as we can, and then identify some community activities, some home activities, some things that you can do to continue to work on your balance, work on your coordination, work on your strength, work on your hand function. So the surgical procedure doesn't require lifelong therapy, but CMT, and depending on what your presentation is, does benefit from therapy at different points throughout the lifespan. Another question here we have, I guess the person is responding to how long can the benefits be expected to last. And if I understood your response, you said that you've seen this 4-year follow-up in the cases that you presented today, so you know that it's at least at 4 years, I gather longer?
Yeah, 4 years. When the young lady comes in, what she's doing in the spring, she'll be at 5 years, so I'm curious to see how she looks then. And then, as I mentioned, the adult literature has some patients that were followed up to, I think it was 10 years and still sustained benefit. But again, it's not you know, there's nothing that says here's a study of about 100 patients that had it, and we can definitively say it's going to last you 12 years. So I think, you know, what I take from my case series is that I took 2 patients who I view as poor surgical candidates because of the weakness, because of the atrophy, because of their disease progression, and because of their impairment. And 4 years later, a poor surgical candidate was able to still maintain function and benefit from a surgery. So my thought is that, as we discussed a little bit, somebody who's starting off with a lower level of impairment, a lower level of wasting and atrophy of the hand, would be able to sustain even longer.
Okay, so we've reached the 1 hour mark. I'd like to thank Tim for his time today. I thought it was really interesting. And thank everybody for joining us. And Tim, I don't know if you have any closing comments you'd like to make?
The only other thing is my email available if people have questions that they want to email about. I'm not sure if that's, I think you might be able to get it from the CMTA website, or I'm not sure if that was sent out as part of the webinar.
Yeah, I would think the CMT website. I believe
Okay.
you're listed in the on the board.
Yes.
Screens. Yep.
Okay, so if anybody has any follow-up questions, if anybody wants to, you know, be seen for a consultation, or needs anything at all, or recommendations for daily, you know, other modifications to daily activities, I'm happy to do that. Just feel free to contact me through the CMT website.
All right. Well, thank you, everybody. Everybody have a great day. Enjoy.
All right.